Welcome, everyone, to Beauty and the Surgeon podcast. I'm Amy. I'm a nutritional therapy practitioner, and I'm joined today, as always, by my very spooky co-host.
Very spooky.
Dr. Jason Martin. He's a board-certified plastic and reconstructive surgeon. I am in full-on October denial. I feel like this is where I usually say, like Nils, like, cue the ghosts.
Right.
Cue the goblins.
Yes, all the stuff.
It's October. It's spooky season. You guys love Halloween. This is like your time of year.
It is.
Yes. So yes, cue all the things. Like, let's pop up some, like, what are those things? Headstones? Yeah. Like, Let's get this going. Like, real spooky vibes.
It's very spooky.
Yes.
I'm very spooked out.
The decorations went up early September, so we're...
Yeah, when the kids were
spooky is
young,
on.
I would start about September 15th.
Yeah.
Yep.
That was my time.
Well, so there you go. You guys are well into spooky season at this point because it is October.
So what are we talking about today, Amy?
We have a great episode today. This is part 1 of 2 of listener questions and comments. If you would like to be part of our next listener questions and comments, leave us a comment below or send me a text, leave me a voicemail at 303-630-9038.
See, you let me point, and that's when the number is correct.
Yep. We also, I take every once in a while, these comments are all coming from either text messages or from YouTube, but a lot of times I get questions from TikTok even, or Instagram. So if you're not watching on YouTube, if you're just listening, you can definitely leave us a comment there as well. Spotify allows comments too. So wherever you leave a comment, I will find it and you might be on the next episode. So
nice.
Without further ado.
Okay,
Dr.
so we're
Martin.
doing listeners' questions and comments.
And comments.
Part 1.
So the first one is a text. So this is anonymous, but this was a text. Hi, doctor. Just finished watching one of your YouTube videos. I recently had facial plastic surgery. Woke up from the ankle down with no ability to move or feel my foot.
I didn't read this one.
It's been 2.5 weeks in bed with a boot on my foot. Now feeling some shooting pains and pins and needles.
Yep.
Can't walk or move my toes though. I can feel the scratch test with my fingernail,
That's
except
good.
for my ankle.
Yeah.
There is no feeling zone. Side note, I live in New York City, walking on concrete for years, and I was feeling strange pings in my toes pre-surgery. So I was definitely not in good nerve condition. I was under general anesthesia for only 1.5 hours. I have not had a nerve test done, basically been told it's 6 to 8 weeks recovery.
Mm-hmm.
He did add a second text to me that he is a non-drinker and non-smoker,
Okay.
which I love that he thought we would ask that. Any tips or suggestions? Would love your thoughts. It's very scary, not to mention confusing. What did it? Compression, nerve blocks, pre-existing scar tissue that compressed the nerve, and which nerve?
Mm-hmm.
This was such a good question.
Such a good question. Can't really answer this question because I don't have his clinical stuff in front of me. So we don't really know what surgery he had.
He said facial surgery.
Okay.
Yep.
So I'm assuming they didn't do a lower extremity nerve block with that. In general, like in most cases, probably the case here, especially since it was facial surgery, when you're asleep, your body is usually not, or when you're sedated, your body's not usually in an anatomic position. So it's really important for the staff, the nursing staff, the physician, to ensure that your legs and your arms are adequately placed and without impingement. And literally before every case, I go around and check everyone's legs and arms, not the staff, the patient. Yeah, show me your arms real quick. Are they working?
How are those legs?
Yeah, how are those legs doing? Can you kick a ball? So we'll check it and make sure. And what can happen is there's nerves, especially in the arms, run down on the inside of the arm, but there's nerves in the legs too. If you, do not have appropriate positioning, those can get impinged and then you get neuropraxia. If you already have pre-existing weakness beforehand, that can worsen. Now, I feel like this would be great just to give us like clinical questions and we try to figure it out.
Pearls,
it's like a sleuth. For him, he already had pre-existing issues. I think he said tingling in that leg beforehand. Is that correct?
Strange pings in my toes.
Yeah.
But in his toes. And his ankle is the part that's completely numb.
So what can cause tingling in the toes? Well, number one, your foot can fall asleep. Blood supply to there. Secondly, people with diabetes can actually have diabetic neuropathies. Like you have neuropathies where your nerves are not conducting well or at all. They can have numbness or tingling and stuff like that. A lot of times, in most cases, when you see people and they have a kind of numbness in their feet or their hands, it's usually from the spine. It's usually centrally located. And so if you're just going to play the odds, this patient or this man probably has spinal issues, sacral stenosis or narrowing down at the lower part of the spine that then has this presentation distally at the feet. After the surgery, maybe he had swelling edema, maybe he was positioned wrong, and whatever the process that was going on there worsened. What would you suggest in the situation without really knowing clinically what's going on with him?
I mean, giving it time. The other thing I would highly recommend would be acupuncture, because acupuncture can help with like regaining that nerve firing more quickly.
Yeah.
Even, I mean, if it persists, I would definitely start doing some occupational therapy, just to make sure that you weren't having weakening of the muscles when the nerves aren't firing correctly, just to keep it strong, like doing strengthening. Even things like contrast therapy, like any of those things that trigger those nerves, like with a different sensation, are going to help wake things back up.
Right. Hyperbaric oxygen is a great option, especially in this kind of situation. So if you think you were one way before you went in, one way when you went out, Occam's razor says it was related to the surgery, period.
In some way.
So it could be positioning related. He did question about scar tissue. Scar tissue can definitely compress nerves, but it's not going to be acute. You're going to go in one way and an hour and a half later you're different. He asked about
which nerve compression would it be?
Well, I mean, there's multiple nerves there, and he didn't totally describe exactly. I mean, there's a lot of nerves that go down your leg. It's not just one. Well, technically, it's one nerve that goes down the leg, but it branches out when it gets to the foot. So usually, when people have really loss of sensation below the knee, the area of concern is at your knee joint, what we call the popliteal fossa. But after that, it starts to split off, decussate, and then start feeding different parts of the foot. I can't believe we're talking about the feet, which is so funny. It's the one place I don't operate on.
Yeah.
I operate on everywhere but the foot.
Yeah.
But I want to say that compression garments can actually cause prolonged numbness and tingling if they're too tight.
Yeah, people love to overuse compression.
We talk about this all the time. So again, you said you had facial surgeries. We're assuming you didn't have liposuction of the lower extremities. But if you would have had liposuction lower extremities, wore a compression garment for a long time, just the edema and swelling alone with the compression garment pushing down can cause a neuropraxia, like a pressure injury to the nerve itself. That is 100% possible.
But I agree. This would be scary if you woke up from a facial surgery and you couldn't move your foot at all. Like no ability to move or feel my foot.
Yeah, that's a real problem.
Yeah, that's...
To me, this is positioning.
Yep.
Or you had a pre-existing spinal problem, and then when they put you on the table, you had some instability there. It just kind of things were shifted. Just the idea of you being somewhat sedated, being on a table or from the table and going back to the transport gurney, that something happened in between there that was related to the spine.
The good news is, though, I mean, the shooting pains and pins and needles, as uncomfortable as they are, is really good signs.
Yeah. Yeah. And one last thing I want to say. Again, you consult your surgeon, consult your physician. So we're just talking about this. There are so many reasons that people get shooting weird feelings in the extremities. I mean, we see it every week in our clinic. People have different medical conditions that can cause this. There's medications that can cause it. There's so many. I saw a lady who had familial Mediterranean fever syndrome or fever condition. And that can have numbness and tingling in the legs. It only happens for Mediterranean people. Apparently, it's very common in Turkey and Israel. I just want to make a point that, there's so many different things that can lead to this. But if you go in one way and you come out another, to me, that's the surgery induced until otherwise proven, period. Yeah.
Yeah. So really appreciate the text. That was a very intriguing and interesting question. So
love more information, but maybe we can do it next time. Okay.
All right. So the next one was from a YouTube short. So this was of the BodyTite of the outer thighs. This was from Cindy. Can you achieve symmetry from getting liposuction of the outer thighs?
Yeah.
I told her, I said, in most cases, yes, that you can make asymmetries better, but you probably will never get them to go away completely.
Yeah. Absolute symmetry, no, but a lot better symmetry.
Yes.
Yeah. An improvement in symmetry, of course.
Yeah.
That short, if you look on our YouTube channel, she had a beautiful woman, but she had all of her fat was accumulated in her saddlebag area. So she's way better. It's not perfectly symmetrical, right? It's nearly impossible to make bilateral or both-sided things symmetrical. Absolutely.
But it can make them better. And we occasionally do have a patient who has like an odd asymmetry. And like you can definitely make it better with liposuction. Oh, yeah. Regardless of the location. It could be on the arms or, even on the sides. I mean, like you can definitely make it better.
There's really no body thing that we operate on that we're not trying to achieve symmetry. Breasts, arms, abdomen on both sides, legs, rhinoplasty. You want either side of the nose to look correct. Blepharoplasty, upper eyelids. You want both eyelids to look the same. Brow lift, facelift, both sides. There's rarely a unilateral.
But inherently, people are not symmetrical.
Yeah. The other funny thing is, and so of course, like we are symmetry surgeons. I mean, that's basically what we do, and also make things look better surgeons, people that do the cosmetic stuff. But in reality, no one comes in symmetrical. And then it's funny to see people so concerned about symmetry when they were absolutely asymmetric to start with. Now, Amy and I, we like that. We feel the same way. So we embrace that, but no one's symmetrical. No one is.
But you can make it better. Yeah. So also on this short, we had this one, which I thought was great. Can't find any stories of plastic surgeons undergoing BodyTite themselves. It would improve my confidence in the technology if I knew the surgeons who really knew this technology used it for themselves.
I would do BodyTite myself.
Well, we have done BodyTite on many surgeons. Interestingly enough, we were the regional training facility for BodyTite for many years. And multiple times, surgeons, after coming to the trainings, came back and had us do BodyTite on them.
Yeah.
So, yeah, absolutely. We know lots of doctors who have had BodyTite. So feel confident, Bird doggy.
It's a good question. Now, and I know that things are changing in the internet and then social media and stuff like that, but at least historically, you don't want to make this about you. You don't want to put out your personal stuff to everyone. Well, historically speaking,
I do pause at the fact when I go in for a LASIK consultation, everyone there is wearing glasses. That does give me pause.
No, her point is well taken, but like at least historically in medical training, you make it about the patient. You don't make it about you, or you make it about your acumen, your abilities.
Right. Like if you need your appendix taken out, it doesn't matter if your doctor's had his taken out.
Historically speaking, like patients don't want to hear about your personal stuff. Like what surgeries
all of our patients want to hear about your personal stuff.
Maybe they want to hear about it, meaning that you're taught not to talk about it because that breaks down some barrier, some doctor-patient barrier. Lately, though, with TikTok and everything, it's all out there. I mean, people are just everything on their professional TikTok is about their family and their children and what they're doing and dancing around and being at a basketball game or something. So I think I get now why people are wanting to know more of this, but and I'm not being defensive. I'm just saying at least up until this era, it was frowned upon for board certified plastic surgeons to really talk about their personal life.
Well, or any professional. I agree. Yeah. But I mean, again, it does give me pause when my ophthalmologist office, every single person in there is wearing glasses.
I mean, you can take my word for it. I would do it.
Yeah.
I can't just do it to myself.
And we have done it on multiple doctors. Yeah. So, I mean, we've done it on a spine surgeon. We've done it on 2 spine surgeons. I mean, we've done it on a lot of doctors.
We're like a spine surgeon BodyTite specialist here.
So feel confident, Bird Doggy. Like doctors do BodyTite on them. They can't do it on themselves, but they have it done by other doctors. Right. I mean, you could, but yeah, it'd be weird. All right. So
what's Dr. Martin doing? Is it their BodyTiting
himself? He's BodyTiting himself. Like, no, if you want BodyTite, I'll do it. I'll do it for you. So this one was on episode 53, which was our original thigh lift episode. What happens if you don't have a fold under your butt? My butt is a bump and doesn't have a fold, and I don't want one, but I feel like I need/want a 360 thigh lift. So I think what she's meaning is that we extend that incision sometimes under the gluteal fold.
Yeah. So what happens if you don't have a fold under your butt, but my butt is a bump and doesn't have a fold, and I don't want one, but I feel like I see what she's saying. Yeah. So like if you're doing a thigh lift,
do you have to extend it? I think that's what she's asking.
You do not have to extend it. Yeah, I get it.
Yeah. So if you don't have a fold under your butt to hide an incision, well, then it's likely that you don't have laxity right there either.
Right. So the banana roll is like really common. Yeah. And then what happens is like the history we always get, the patient goes into some random office and they get liposuction there and it makes the banana roll worse.
Well, it drops the butt.
If you remove the fat, then it makes your fold drop. Everything looks droopy there and you've never been around a more pissed off patient.
Well, and it's hard to come back from that.
Right. You can inject fat back in, but like trying to convince someone they need fat back in their thigh is like trying to tell them they should drink this, cup full of COVID. They're not going to do it. It's very hard to get people to realize that the fat that was taken out was actually structural and now it's kind of ruined. So in some cases when it's really bad and you're doing a thigh lift, you just extend that scar or the incision over underneath the butt and take out the banana roll completely. I don't do that all the time. I don't like doing it unless I have to do it.
Well, and if somebody has a natural crease there, it's a great place to hide a scar. And if you have a lot of laxity on the very back of your thigh, it's the only way to address that.
I remember the patient was asking us, well, can't you see it when you bend over and you're totally naked? And then she's like started to bend over. I'm like, this is not what we need to worry about.
Well, no, I always tell people if someone is seeing your scars when you're in those kinds of positions, you know that they are and you have allowed them to see you in that position. So if they have a problem with it, well, then they don't deserve to be there.
Also, like you're not at the library showing people your infra butt scars.
That's my point. Yeah. or underneath your breasts. Like if someone's seeing your scars,
Yeah.
it's because you've let them. And
Yeah.
if they have something to say about that, well, then you don't need to let them.
Right.
Yeah.
Because you are the key to happiness. You control happiness. If you're letting them be happy, then they should be thankful.
Yes. So we had another comment on this episode also. So episode 53, yet again, from thigh lifts. This was from Pearl Tarjanet. Thigh lift surgery scars are horrible, and I advise dark-skinned people to steer far away from this surgery. There is a rippling and pulling, especially if it's not vertical and down your leg. Can't even wear shorts. That's what surgeons don't tell you. Do you agree with this comment?
No.
We tell everyone about the scars. In fact, if you've listened to any of our other thigh lift videos, we talk a lot about the scars. And the way scars look on any color skin is different. I mean, we have patients with dark skin whose scars look better than someone with really light skin. Like the way you scar is unique to you, and it's also unique to the surgery. If you have rippling and pulling and other weird things, like that might be more of a surgical issue.
It might be more of a technique issue.
That's what I mean, a technique thing. So
I mean, I really appreciate this comment, and I understand what she's saying. If you have dark skin, the scars are in large part going to probably look worse. The blessing of darker skin is that you age better. You just look better than Amy and I.
Have better skin.
Yeah.
Tensile strength.
But the consequence of that is the scars can be hypertrophic. They can be, you can get keloid scarring. It's way more common in people with skin color, with melanin in their skin.
Mm-hmm.
And then this idea that you have rippling and pulling after a medial thigh lift or inner thigh lift, maybe right away, but after a month, you shouldn't have that.
Well, it might take several months for things to loosen up. I mean, pulling can mean a lot of things to a lot of different people. Like some people want the pulling, like they wish we'd pull more. They wish we'd have more pulling.
Yeah.
So these things are very subjective, and like some amounts of rippling. I mean, if you have lots of laxity, I mean, is there going to be rippling to the skin in some areas? Potentially.
But it shouldn't be long term if you do it right. I don't know.
Or if they have really poor skin integrity, like there might be some areas that do have a little bit of rippling that was there prior to surgery.
Yeah.
The thing that can't be taken away completely.
The thing that bums me out about this comment is she says I can't wear shorts. And that kind of it's distressing. So you can wear shorts.
Mm-hmm.
You hopefully are better, but not every surgery is perfect. And you're right. If the surgeon didn't talk to you about that, didn't talk to you about scars, didn't talk to you about the location, if rippling is normal for what they did and they didn't tell you about it, yeah, you should be pissed off. 100%. At least in our office, Amy and I are brutally honest with people every week.
Well, I don't think being angry about something is the right way to go about it, but not being, not feeling like you were informed, but like going to say that someone is pissed off about something, that's different. I mean,
yeah. Okay,
you have to advocate for yourself.
You have to advocate for yourself.
Yes.
That's what I'm saying.
You need to be educated as well.
Right. Maybe pissed off is not the right word, but it's okay to be frustrated because
your
I would be
surgeon should tell
frustrated
you.
in this situation. Yep.
We have a great episode on scars that go over all of it, and I can say that every
Right there.
recovery for every procedure we talk about, a lot of it is how to take care of your scars, things that you need to do and avoid, or just like taking care of your scars makes a big difference.
Big difference.
In recovery.
Nutrition.
Yeah.
Yeah. 100%.
Always preaching that with every procedure, even if it's a tiny little scar behind your ears or something like that.
Yeah.
It's sunscreen, it's care,
and surgeries come with scars. And the trade-off of loose skin might be that you have a scar. If you weren't wearing shorts before surgery and you won't wear them after surgery because you're now afraid of your scar versus the loose skin. I mean, look at people who have knee replacements. They have scars straight down the front of their knee. These people wear shorts. Like, I think ultimately, like, people don't put the same amount of emphasis on someone else's scars that you put on your own scars.
Yeah.
Like the inner thigh lift, I mean, unless you are, we were just talking about positioning. Legs spread. We talked about this in our thigh lift episode about man spreading. Yeah. Which you did not like that I said man spreading. But, if you're sitting with your legs like spread open with really short shorts on, could somebody see that scar? Like, yeah.
That would
potentially.
be interesting. Yeah.
But if you're sitting with your legs together, can they see it? No.
I don't want to be sitting here looking at this.
Exactly. Yeah. It's a strange thing. I mean, I had someone tell me today they couldn't wear a swimsuit because they felt like they had a little bit of back fat. And I'm like, yes, you can. They're like, no, I can't. I'm like, yes, you can.
Yeah, you can.
You can.
Yeah, you can do it, Pearl.
Yes.
But we're sorry that it sounds like you maybe have that we have a great episode on unwanted outcomes. And it sounds like you have one of those. So I'm truly sorry, Pearl. I mean that.
Well, this is why we do the podcast, because we do tell people the truth about these things. Like Nil said, like we talk about scars in every single episode.
Any
we talk
darker
about scars.
skin person that I'm doing a thigh lift on, I'm going to have about an hour conversation with a dark skin person about scarring.
Especially about a brachioplasty, visible scars, even on a facelift.
Yeah, to the point that they're like, we got it, Dr. Martin. Shut up. We heard you. You've said it 12 times.
We say these things.
Yeah.
Yeah. So unfortunately, not all doctors do, but we do. Yeah. So we are changing the tide.
Doesn't make us better, but we're sorry for you. Okay.
Yeah. All right. So going way back in time, this was a comment that we got on the BodyTite live stream, which people still comment on because you, or that was maybe on the BodyTite one where you drew on my arms. People comment on that one still too, but BodyTite live stream was a long time ago. And this comment was from Lydia, and she said, "One leg is big than the other" from poetry.
Is that like a haiku? I don't understand what she's saying.
I don't know, Lydia, but I liked this comment up. I'm going to put it up there. I don't know what it means. We weren't talking about the legs, but I'm still putting it up there.
I like that.
Yeah. Like, okay.
Seriously, if you're talking to someone, you're having a serious conversation, you just look at them, just pause for a second and say, listen, I just want to tell you that one leg is big than the other from poetry. And just look away, like, it was very meaningful.
I have to note that Sarah pours these as are, spelling and everything, just because we want to keep it authentic to what people are asking.
I didn't make a comment on the butt being spelled B.
Nope, I leave it. I leave typos. I leave them.
I start and go, nope. That's the agreement we have, is we pour them as we get them.
No, man, dude, if you want to spell butt B-U-T, I'm with you.
Yep. Yes. If you put emojis and lots of weird punctuation, I leave that too.
I love it.
Yep. Yeah. So Lydia, I don't know what that meant, but I appreciate your comment.
Thank you, Lydia.
Yes.
You're a good listener.
Yes. So this one also from an older episode. This is from episode 124. This was breast reduction 2.0.
Yeah, it's a good episode.
You guys are amazingly knowledgeable. Thank you.
Thank you.
Note, I know of a surgery that occurred 1 week ago. I love this. Just so happens I know of a surgery that occurred 1 week ago. So if you had a reduction in the middle of menopause, it could come back, but could it shrink? I hear a lot of 50-year-olds going through reduction. Also, if you have Ehlers-Danlos, is it normal for your nipples to point towards your nostrils right after surgery? Do they normally look too small at first? Lots of questions here.
Okay. So
let's talk about the first one. So after menopause.
Yeah, why don't you just break it down for me so I can answer this?
So you have a reduction.
I feel like every one of these people writing in is my son with ADHD.
So you have a reduction during menopause.
Okay.
Once your menopause is done, once you're menopaused,
right,
are your breasts going to continue to grow or shrink?
Well, breasts as we age, the breast tissue gets replaced by fat.
Yep.
Per the data, we get heavier and heavier, more fat, higher fat percentage each decade of life. So technically speaking, they should probably get bigger. But it doesn't mean that's what's going to happen. Some people do lose weight after menopause. Some people gain weight. It just really depends on your hormonal balance, your genetic makeup, your metabolism. So it's hard to say. I think in general, it might get bigger. So what we see is we'll do breast reduction on people in their 30s, and then they get perimenopausal gain weight, and then we'll reduce them.
Or relift them.
Relift them in their 50s.
Yeah.
All right. What's the next one?
So then she potentially, the same person has Ehlers-Danlos. Is it normal for their nipples to point up after surgery?
I don't know. I mean, last time I looked, there's 8 different types of Ehlers-Danlos. When I was coming up, there was 3. So basically, Ehlers-Danlos is an inability to heal well, not getting into
collagen
issue, but we're not going to get into it. But it's basically a healing problem. And also people with Ehlers-Danlos, the real version, the kind of more problematic version, are hyperflexible, and more importantly, they have a higher incidence of aneurysms, especially aortic. So I think Abraham Lincoln was believed to have Ehlers-Danlos because he was hyperflexible, tall, that kind of thing. Anyways, doesn't matter. That's a healing issue. So of course, if you're going to do a breast reduction, which is a big surface area, especially if you have large breasts, big surface area, and you have Ehlers-Danlos, you're at higher risk for healing issues, higher risk for scar formation, and higher risk for postoperative complications, for sure. Now, there's all different types.
That has nothing to do with her nipple pointing.
No, I know. There's all different types. And if you have a lesser version that you may be able to heal for it, we've done Ehlers-Danlos patients before. Now, nipples pointing toward the ceiling absolutely should not look like that after surgery.
Right. I think what she's getting at is, will her Ehlers-Danlos, did they maybe do that to overcorrect because they feel like the Ehlers-Danlos is going to allow them to drop more?
Okay.
That's kind of where I think she's going with that.
Probably, Man, are you rolling the dice on
Exactly. I wouldn't roll that
that?
dice.
Whoa.
Yep.
Because if it doesn't,
Yep.
Dude, I mean, you can fix it, but like, you know what I'm saying? You already have Ehlers-Danlos.
Mhm.
You're already kind of rolling the dice a little bit.
Yeah.
Yeah, that's a tough one.
Because typically after a breast lifting procedure / lift, we talk about this in our episodes that like a lot of times the nipples will point down because of swelling and inflammation and
which is actually by design, because you don't want to overlift the nipple and areolas, because that's the worst case scenario.
Right, because you don't want them
right. You don't
out.
want it to look like the breasts are bottomed out and the nipples are pointing up. It just doesn't look good. Now, some people like that, but rare is the person. So most people like their nipples pointing straight out. And if you don't have at least nipples pointing straight out or pointing down after surgery, that's a problem, because they're only going to end up pointing up higher, not lower. If you have Ehlers-Danlos, you would not lift the nipples at all and then let everything fall into it.
Right, because as the breast drops down, they're going to want to point more up.
More up, yeah. So real problem.
And
again, we don't. I'm sorry that you're dealing with. God, these are all hard
well, we
ones.
don't know. This was a hypothetical.
Oh, okay.
Yeah, this is hypothetical. I think you got to stop reading so much into these patient experiences.
This is a very specific hypothetical.
It is. It's very, very specific.
Not me, but I have a friend who may have problems with ED, Amy.
Right.
That's what it sounds like.
Exactly.
Yeah.
The question about do they normally look too small at first? Again, I would think potentially related to the Ehlers-Danlos, do we think that maybe this surgeon erred on the side of too small because they thought that they would stretch as the healing happened?
Oh, man,
Again, I wouldn't roll that dice, because I know from a lot of experience doing this, it is rare that we don't have we have patients who like their areola to be larger than they are. And once they're too small, you can't go back and make them bigger again. So that is something you should talk to your surgeon about, because this has been a real discussion I've had with patients after surgery, that they kind of liked their bigger areola. And now they do feel like they're maybe a little too small. And this is more so when we do a breast augmentation, because now their breast is bigger and the areola is smaller. And now they...
In comparison to the breast size, yeah. The areola would technically get bigger with a breast aug because you expand it out. But when
you're doing a lift at the same time and you make them smaller.
Yeah.
So
I just want to clarify. Yeah.
Yeah. I mean, my thought is with all of this, if these are the issues that this person is potentially, this hypothetical surgery had this outcome of nipple and areola, or an areola that is looking too small and nipples that are pointing up, could potentially they were trying to err on the side of laxity that may or may not occur.
I don't know, man.
It's a tough one.
Yeah, it's a tough one.
Yeah. So
write us again. Tell us how it's going.
Yeah. Could your breast grow or shrink after surgery? Yep, they sure could. Ehlers-Danlos can affect healing. Your nipples shouldn't point straight toward your nostrils. And if they're too small now, they probably won't get a lot bigger.
Yeah.
Yeah. Yeah. So with that happy note, we're going to take a break.
Happy times.
Yes. And we're going to come back. And
what was it? Like happy nice or soft nice?
Soft nice.
I just want soft nice questions.
Yes. Well, we got more comments and questions coming in the second half.
Thank you.
And we're back with more questions. All right, let's jump right back in. So this is from episode 169, Everything You Need to Know About Breast Reduction, Part 1. There were a lot of comments on the thigh lift episodes and the breast reduction episodes in the last couple months. This woman asked, Elizabeth, she asked, I am 63, healthy, non-smoker. Am I a candidate?
Hell yes.
Yeah.
As long as you don't have other medical problems.
So I told her, I said, most likely you are.
Yeah.
Go get your breast reduction.
Go
Don't
get
wait.
It done. You're not too old.
Yeah,
Yeah.
absolutely.
Life doesn't start. Stop.
Life doesn't
when you're
start.
after 60. I mean, you're still living. Go get your breast reduction for sure.
Exactly. Yes. So also from the same episode, this was from Lynn Dattelford.
No, Lynn Date Ill Ford 4370.
Yeah. Gosh darn, that decimal system really confounds us. I had to put this one up here because we were talking about the schnur. The grams.
Yeah.
Yes. Love that comment.
Right,
Yes.
That's very funny, actually.
Gosh darn that decimal system.
Yeah.
I love it. Yep. All right. Moving on to brachioplasty. This was from Liesl Sloan, episode 136, Everything You Need to Know About Brachioplasty. So I take it you don't do Renuvion anymore. Is it because of the above risks of uneven skin and worse? So Liesl, we demoed the Renuvion once and we never did purchase it. We were not impressed with it, and I think we made the right choice.
Yeah, I do too, but other people...
BodyTite's just way more powerful.
BodyTite's better in our mind, but other people use Renuvion with apparently good results, so we're not against Renuvion. Now, there was an issue with Renuvion.
Yes,
we're being honest.
The
it was
FDA
taken off the market because the FDA put a black box warning on it or some sort of warning, and that apparently got worked out for internal use. It was only for external use that you could use it for. That's a little concerning, but there's a lot of reputable surgeons that use Renuvion and get results and like it. So.
But for us, we found better found technology that we liked better.
Tomato.
Yeah. So, and we actually never used it on arms. So, yeah. Also, yeah. All right. Love this one. This is from Lady Nipchick 2.
Nice.
This is from our YouTube short. Is a deep plane facelift superior to a SMAS facelift? Me again. You've mentioned potential nerve damage with deep plane. What about the apparent need to cut the ligaments in order to better raise the SMAS? Will that really improve the outcome and longevity of a deep plane facelift? I mean, you already said that as long as the SMAS is dealt with correctly, both types of facelift seem to last as long as each other. So why cut ligaments unnecessarily?
So there's a lot of ligaments there. I'm not totally sure exactly what she's referring to, but there are ligaments that go literally from the bone to the skin. And for example, there's some up in the cheek area. Those loosen over time. Some in the jawline. Some loosen, some don't. So you get the jowling. The jowling bows down below your jawline and back up. That's a ligament there. So you have to sometimes release those ligaments to allow for redraping not only of the SMAS, but of the skin too. And a lot of times those ligaments are going to be quote unquote cut, the external ones or the superficial ones, with a deep plane or a non-deep plane facelift.
Yeah, they'll cut them either way to release it. Yep. So
in terms of ligaments for a deep plane, there are some things you cut, but I think that's just part of the technical aspects of that surgery itself. No matter what you want to believe, if we are talking about reality, at least per the data, and through our anecdotal experience also, because we do everything, there's not a big difference between a deep plane facelift and also the other types of facelifts, as long as you treat the foundation substantially, period. But I mean, the data is going to be problematic. You're not following people for 20 years. They don't have prospective studies starting in year 2000 when they started doing deep plane facelifts or whatever.
Right. And these people didn't eat the same diet. They didn't stay out of the sun the same amount.
Yeah.
Like they didn't have the same lifestyle. They didn't, all these things affect how people age. That is different person to person.
Person to person. So what we've always said, you need the surgery you need.
You need the facelift
not
you
the
need.
one that you saw on TikTok or the one that your friend had. So you need to go to a reputable surgeon that does all the different types of surgeries. And if you go in there and they only do deep plane, I have a problem with that too, actually. I mean this. So please, it's not always about deep plane. It's just the surgery you need.
Yep.
It's a good question about the ligaments and those attachments. You do divide some of these things because you have to be able to readjust and suspend not only the foundation, but the skin too.
Yeah, because you'd just be having that. You'd be fighting it.
Yeah.
And be unable to get
and you can see it
result.
on the table when you do it.
Yeah. Yep. Yeah. I mean, the truth of the matter is that when we do surgery, we cut through a lot of things. And I say this on was it the episode about scars? Nils probably knows. People always ask me about the scar, but they never ask me about like the lymphatic system. Like, did you placate my lymphatics? I think it is on the scar episode. They don't ask about that. Like, they don't care if we slice through all their lymph, system during it. Just they want to see the scar. So, yeah, in life, there's no free rides. Mm-mm. Everything has something to get the right result you want. Yeah. But ultimately, the facelift you need is the facelift you need. And we say that in that video, I think. That was a good one.
Good question, though.
Yes. All right. On to episode 110, Thigh Lift 2.0. Can you not sit after all the types of surgery or just when you have the incision under the butt? This is from Debbie Ermier.
If you do a hockey stick vertical thigh lift, it would be a lot easier to sit. But even in the sitting position, you're going to put tension on certain things. At the very least, you're going to kind of bring your groin over, and that's going to hurt. Mm-hmm. You're going to feel that. It's going to be pulling on the inside near where your labia or your scrotum is, like where it turns, the hockey stick turns. So, yeah, but it would be much easier to sit with a vertical than it would be for a medial thigh lift that goes along the gluteal crease.
Yeah, but there's still going to be uncomfortableness with sitting even after we just do liposuction of the inner and outer thighs alone, which we would probably be doing with this as well. It's uncomfortable to sit. So what your restrictions are will be specific to the surgery you have, which is why we always say, follow your surgeon's recommendations for post-op care.
Board certified plastic surgeon.
Yes, especially with the thigh lift. So also on the same episode from Karen, we had, can a person who lives alone manage after surgery? This is a complex question, Karen. If you listened to our most recent thigh lift episodes, we do a much deeper dive on the recovery in part 2, where we talk specifically about what to expect week by week. You won't find a surgical facility that does elective surgery on patients who does not insist that they be discharged to a real human over the age of 18 that is not like an Uber driver
or a Lyft driver.
Yeah, has to be a responsible party. And most surgeons are going to insist that that person stay with you for 24 hours after surgery. After that, could you manage? Potentially. Is it ideal? No.
We've done surgery in people that are by themselves and they just don't get sedation. They only get local anesthesia. That's totally fine.
Right, but I mean, not after a thigh lift.
No, not after a thigh lift. Yeah,
that's what she's asking specifically about a thigh lift. Yeah. I'm like, no.
A thigh lift under local?
Yeah, no. Well, and even if you had a thigh lift under local, I would still want you to have someone with you because you're going to struggle with things like getting off and on the toilet.
Getting in and out of the car if you drove there. Yeah.
Yeah. So I would recommend a minimum having someone with you for 2 days after surgery. And then at that point, as long as you were, functioning well and off your pain medication, onto Tylenol only, because you really shouldn't be left alone if you're taking narcotics or muscle relaxants or other things that are making you not, completely in your right mind. So I would say, can you manage alone after surgery after 48 to 72 hours potentially? Yep.
We also talked about in the lower body lifts that, there's scars and stuff, incisions that you can't see because they're behind you, and you drains that need to be. So there's a lot of
getting help off the toilet. Yeah. Being able to turn over, clean something.
It just really seems like you need someone and someone who's not grossed out and someone who's strong too, because if they're moving you around and stuff.
So Nils is saying that he'll come help you, Karen, in 9W, because you're strong and you're compassionate.
Volunteering my services for post
thigh lift care. Some strange Viking man will come to your house.
And someone who you are comfortable with seeing all your incisions. Yeah. So
I'd take care of you.
Think it through, Karen. I would take care of you.
Good. Nice.
Yeah. Yep.
Let's pack that out. Let's shake on it.
Deal.
Okay. A deal.
All right, so we're still on the thigh lift train, but this is now from Deborah.
Man, this is like thigh lift everything.
I told you there were a bunch, and I don't know if it's just the time of year or what, but this was they're all from different thigh lift episodes, though. This is from episode 158, everything you need to know about thigh lifts. So to Karen, make sure you listen to episodes 158 and 159. Does a thigh lift fix the excess
by the way, this
skin?
is Deborah Stevenson 6426. I can actually read this one, so cool.
Yes. Does a thigh lift fix the excess skin at the junction of the thigh meeting the buttocks?
Yes.
And we talked about this for the person who doesn't have a crease there, who probably doesn't have laxity there. But if you do, you probably have a crease there. And yes.
For a medial thigh lift. And also you can do a hockey stick vertical and then also tee it off and then go back behind the butt. There's so many different options.
Yeah, we've even come up around the hip, like around the...
Right.
Yep. So yeah, you chase that skin out as far as you need to. Because if you're doing this, you
got
loose
skin, I can make a scar that gets rid of it.
Yeah. Great question. All right. That brings us to the end of part 1. Definitely come back for part 2, because in part 2, I have more of the comments, more than just the poetry one, though. I had to throw in there. I was like, I kind of went back and forth. I'm like, should I put
the legs aren't symmetrical.
One.
And one is not. What was it? Here, go back to it.
I got to go back to it.
Let's just read it real quick.
Yep.
One leg is big, then the other from poetry.
Lydia, we got you.
Yeah, we got you, Lydia.
I don't know what it is, but we like it.
Yeah. I found my next tattoo.
Yes. But you have to put it in Sanskrit because no one can read it.
Yes.
Yeah.
In Elfish.
Yeah, or Egyptian. Egyptian, hieroglyphics.
That is
that's a great hieroglyphics tattoo. Do you know what that means? You have no idea.
No idea.
Yeah.
So if you would like to be featured, it won't be our next episode because our next one is coming out in 2 weeks and the questions are already in. But on the next episode of Questions from Listeners, be sure to follow us on social media. And also you can send me a text like our first listener, 303-630-9038. And we will see you all here next time.